about it, close to around 23,000 people were injured and 9,000 people lost their lives, right? If you see this situation, how can you apply mHealth where there is no infrastructure, there is no connectivity, there is no electricity? You would think that mHealth might not work here. But really proud to say that mHealth did work there, based on one clinical decision support tool, which is basically the downloadable version in a smartphone which is available even offline. And it did help to save lives. And you know, in an emergency situation like this, an earthquake, things like that, a doctor, every doctor is supposed to do not more about his specialty, but things that are out of his comfort zone, that are out of his specialty. And that's where this tool, which is clinical evidence-based tool, which can guide the doctor to give the treatment in 90 seconds, give the answer to the doctor to give a treatment to the patient in 90 seconds. That's what this tool is all about. And it really helped there. And we heard that from the doctors who actually used it in Nepal. And also we heard from Dr. Goodwin from Harvard, who reviewed the fact that, you know, he did not use it when he was deployed there, and he would definitely love to use it when he gets deployed again in Nepal or any other situation. Now, what I talked about just now was more about an emergency, you know, a catastrophe. But imagine a daily scenario. You'll be surprised to know that all physicians, in 2 out of the 3 clinical encounters they have, you know, they get 11 questions a day, clinical questions a day. But what's surprising is that 60% of those questions that the doctor, when they're treating the patient, go unanswered. And there are multiple reasons for that. There's a humongous amount of research. How do you look through that data? How do you find that answer? There's very less time. And you know, some people might think that probably there's no answer to these, one of the 11 questions. But the fact of the matter is, if those questions were answered, 5 to 8 patient decisions would get changed. And now that's really remarkable, right? If those questions. Now that takes me to mHealth, where if it is powered with clinical decision support tool, the one that I just talked about, what made a difference in Nepal, it can really help to answer those questions and change the patient decisions that are being made every day. Now, let me go closer to home. You know, all of us know about the infrastructure challenges that we are facing in India. You know, we are the lowest in terms of practitioners, but population ratio, lowest in terms of hospital beds to the population ratio. But we do have a great opportunity in terms of mobile. You know, the earlier panel talked about increased proliferation of internet connectivity, mobile connectivity. India is going to be the 3rd largest smartphone user. Now, this gives us a great opportunity to have mHealth clinical decision support tools which can really change the effectiveness, the way the patients are being treated. Now, the question then comes in, will doctors use it? You know, if we give them, will the doctors use it? I would say vehemently yes. And the reason is not based on what I'm saying, but backed by true research. The research was done with 68 countries, and 77% of the doctors came out that they are using their smartphone when they're treating the patient. Now that's remarkable. But then you'll say that it's a global study. India, things are changing. For India, these numbers are close to 25%. There are close to around 75,000 doctors who are on LinkedIn. More than 100,000 doctors who are using these tools today. So India too has a great opportunity to get these evidence-based technology. Now, there are 2 major focus areas. I mean, mHealth can play entire ecosystem. It can make a difference. But I would say there are 2 main thrust areas. The first thrust area is the solutions in the patient pathway. The second is healthcare system strengthening. Let me first talk about in the patient pathway. Here I would like to introduce you to a tool. Can you imagine, you know, I talked about the Nepal story. In this smartphone, without internet, if you can get an answer, if a physician can get an answer to any questions related to 22 clinical specialties, an answer which is truly evidence-based, an answer which has come out of the journals published as of yesterday, an answer which is vetted by 5,000 experts around 61 countries. You know, this tool is called UpToDate. It has that answer. And it has been in use for over 20 years and well researched. You know, just to quote the one that is on the screen, the Singapore National University Hospital did a research. When the doctor, when he was treating the patient on the bedside, when he used UpToDate tool, the tool that I talked about, he changed his decision in treating the patient 37% of the time. So that's the power of the tool. You know, just to quote another research which was done by Harvard Medical School over a span of 3 years. So they researched over 3,000 hospitals in US, and they concluded after 3 years that hospitals which were using this tool saved 11,000 more lives than the hospitals which were not using this tool. So a remarkable tool, and you know, imagine the situation, the infrastructure problem. You know, we just heard about the PHC. You know, in the first session we talked about in Northeast, there is PHCs being used. The doctor is sitting in Nepal, in Tripura. How can this affect? I mean, if you have this tool available even in the PHC, in the mobile phone, in the smartphone, they can take the decision then there. So this is with regard to the patient pathway. And by the way, some of the countries have actually subscribed as countries. You know, the countries on the screen that you can see, these countries have made this tool as their way to treat patients for the entire country. You know, there was a talk about in the earlier panel discussion about medical education. 90% of the US medical education colleges are using this tool. More than 70% of the US doctors are using this. Now, India is also not far away. We have just started the journey, but we have few thousand of our customers already using this tool, and their response on the efficacy is on the right-hand side, as you can see. 95% of them, just the survey that we conducted in 2014, said that they really found this tool to be useful and affecting you know, how they were treating the patient. Now, let me just move on to the second thrust area for mHealth, which is more about how to change the healthcare system. Request you to play the video.
Mr. Sai, I'm sorry, I'll have to make your closing remarks, sir.
POC Advisor, an electronic system designed for the early detection of sepsis. How does it work? A new patient's vital signs and lab results are relayed from the EHR to the WK cloud service via a secure, HIPAA-compliant, encrypted VPN link. POC Advisor supports a wide variety of exchange formats, including all standard HL7 interfaces. Once received, the language engine maps the diverse data to standard terminologies. Behind it all is a rules engine built on clinical knowledge from rich content sources like UpToDate, Lexicomp, and Provation. The rules engine accesses the standardized data and executes thousands of clinical scenarios to determine what decision support is warranted. In this case, the analysis indicates that the patient is suffering from severe sepsis. POC Advisor then delivers relevant, succinct clinical decision support to the appropriate device at the point of care. The nurse is alerted to begin treatment for sepsis and is prompted to communicate with the on-call physician. The physician confirms the decision support recommendations, and the patient receives the appropriate treatment. POC Advisor has helped to save a life by quickly delivering comprehensive decision support in a convenient and actionable manner.
Just to close then on this, sepsis, as all of us know, that it's a blood poisoning. And this clinical trial was done in John Muir Hospital. And it was done in some wards. They provided this tool, and some wards they did not. The results were fantastic. The wards they provided this tool saved 50% more lives than the wards they did not provide. So, you know, I would just like to conclude by the last slide saying that mHealth is here to stay. But then it can really be harnessed true power if we have clinical decision support coupled with mHealth. Thank you.
Thank you, sir. I would request Dr. Sandeep Diwan. Head of Department Critical Care, Fortis Escorts Group.
Okay, let me begin as an end user first, because I'm the one who uses all this data that gets generated, and I'm sure there must be some of you who must be still thinking, okay, this is more about data collection. What do we do with this data? Because that's also the second part of it. So I'm a practicing critical care physician in Fortis Group, and I also run a group of ICUs across India by the name of EICU, which you are seeing Critinext, which we called as Future of Critical Care in India. Now, I divide data into two forms. One is an acute data. Acute means data analysis right there and that point of time, as everybody has shared, and can it make a difference to the life of the person at 2 a.m. in the night? Because the way India is developing at this point of time in small cities, we get a lot of good physicians who do a lot of good OPD practice. But if I need good emergency care in a small city at 2 a.m. in the night, I'm sure most of you would be saying it's difficult to get. So that is where the difference between life and death lies, and we all know that what we do in the first 1 hour, it is known as the golden hour in critical care, makes a huge difference between the life and death of the patient. And I'm sure this POC advisor that you are doing as a patient of septic shock, it will go a long way in helping these kind of patients. So that is one part of data, and one is the chronic data. Like if you are making a difference in the life and death of a single patient, it is assumed that it should ultimately make a difference in the mortality, and you had shared up some of the data from US. I will try to share some of data from India, which we have been trying to generate in last 5 years on whether we can make a difference in the outcome. So I'll not go into too many details, and we know what are the objectives that we are in. I'm sure most of you have interacted with critical care at this point of time, because all of you have been in the healthcare industry, and it's the backbone of any healthcare system. We call it the next stumbling block, because as we are aging population, most of us will somehow end up in the ICU. Those days of us ending in the homes we are not lucky as much as our grandparents or our previous generations were, and most of us will end up in the ICU. So it's a requirement that is going to only increase, and this is a typical ICU look like. How EICU started is a very interesting story, because we got a call in 2010 in one of our Fortis hospitals, which is way far in Raipur, about a kid who had been operated by a cardiac surgeon, but somehow even after 10 days of surgery, they could not get the kid off the ventilator. And that was a time when 3G was launched in India, and we had a Samsung tablet, and they showed us the data of that patient with the help of that tablet, and it was fortunately launched in Raipur also, and we could save this, the kid, got him off the ventilator, and he still comes from follow-up. And that's how this whole EICU concept we thought came. We know that critical care is all about gadgetry, about monitors, about ventilator, about technology, but then we have to help patients in the smaller cities also, and that is where it helps. This is what we feel is the way to move in the acute stage when you are trying to help a patient. We have an aging population. We have very less availability of critical care physicians all across the country. We produce only 60 in a year. I happen to be one of the teachers, and the requirement is huge. We have to develop some system by which we can save more lives in the acute scenario. And obviously we have to benchmark the quality of intensive care. I'm sure Gopal must be realizing it, and we realize it very frequently in Fortis. While in Delhi NCR will give this level of care, the level of care in the same group hospital at the tier 2 will be a huge difference. While the expectation of the consumer is that if I'm going to a Fortis ICU or a Manipal ICU, I'll get the same care as I'm getting either in Bangalore or in Delhi, which is not the case, which is not the real-time case. So this is what the models like POC Advisor or models like EICU should help in monitoring these patients and helping save more lives. And this is what we started is, as I told, we started with a smartphone. Then we moved on to camera, servers, screens, Smart alerts, we created the first smart alerts in Asia. Then we did the LIS, HIS integration and happened to be more of an IT guy now rather than a critical care now. And now we have moved to remote audiovisual connectivity, EMR connectivity, and we have moved to a system where you can see any patient from anywhere. You can do tripartite discussions and we can help on the clinical front. While most of the data in healthcare is now being generated on the revenue front, the billing front, but I think the time is coming now because ultimately the healthcare will have to move to a clinical documentation and the clinical improvement, because that is what has been lacking for the last 15 years. And I agree with you, Gopal, when you said that this is the area to work on because nobody has concentrated on the data. This is how we document outcomes. You can look at the patient, you can look at the data, you can look at the blood pressure changes immediately, whether it's happening in Raipur or Amritsar or Dehradun or anywhere, and you can actually tell the doctor on duty who's only a MBBS or sometimes even not MBBS to titrate the medication, how much fluid to give. In medicine, it's 11 questions as you were mentioning. In critical care, there are 50 questions that are coming to your mind on how do I things do in that 1 hour so that I can save the life of the patient. This is what the data shows in EICU, and this is what the command center looks at. You are getting the data on the right side are the command center screen, on the left side are the alarm system that we have designed, which get generated in the command center, whether it's any other tier 2 cities, and that's how you help the patient in the night. So this is the audiovisual on which we rely. On the left side, the software that we rely. The software is available, but ultimately you have to connect everything to give a clinical delivery system to the patient. We have documented lower mortality in an Indian scenario, and I agree with you on the US data. We have been able to decrease the mortality by about 50 to 60%, and it's published now in the international literature by our name. We have decreased the complications on intensive care to about 30 to 40%. We have documented better bed utilization with ALOS, although that's a soft predictor of quality. But the most important predictor are mortality, which we think it changes. And obviously, it's very satisfying for the patients because ultimately in India, the patient doesn't shift from a city, the family shifts from the city to a larger hospital, and they have to carry a lot of baggage with them. And if you can counsel them, no, this patient can be managed in a small city with this kind of a support system, they will be at ease and they are very, very less anxious. For the doctors and the nurses on site is a boon. Let's accept it. The poor resident doctor in the night duty will take a nap. Let's accept it. He's a human being. He has to sleep for 2 hours, 3 hours in the night duty. And obviously, whatever you may do, he will still sleep. So he also knows that there's a second pair of eye which is watching my patients, and he can also raise an alert whenever there's a problem. So it leads to a lot of patient nursing satisfaction. Some of the data, we have been able to reduce the number of cardiac arrests in the smaller institute to the tune of, I would say, 100% mortality to 50%. We found a site where we entered any patient who had a cardiac arrest would die. So there's no return of spontaneous circulation. Obviously, with the tool, with the data, with the on-site management, we have been able to make a difference. Post-EICU, out of 484 patients, 40 had cardiac arrest with 24 deaths. So we have been able to save 16. While in the pre-EICU era, all 59 patients who had cardiac arrest would die. You can decrease the infections with the EICU mechanisms, you can decrease the ICU stay, and more importantly, you can give the same level of care. I would still agree with a little bit of difference between the spokes and the hub. These are the alert system, and now let me come to the large data analysis, because that's what the key aim of this. When you get large data analysis, you can actually try to understand what is the profile of the patients that are coming to your ICU. Are you dealing with more septic patients? Are you dealing with more chronic-ated patients? Are you dealing with more liver patients? For example, we run an ICU in Punjab, and the chronic liver disease in Punjab is huge. We run an ICU in Kathmandu, the liver disease is huge. When we go to east side of the country, the disease profile is completely different in the ICU. So that's something which can help. This is what the data that we track. This is the publications that we have done in the EICU. So this was in Jan 2014 in Society of Critical Care, because all mechanism data is generally generated from US. Now we published this paper on the future of medicine, India's first tele-ICU Critinex, can it make a difference? Then this was a very good presentation in Paris in 2013. India's first EICU, changing paradigm of healthcare delivery in developing world. And second, can we decrease antibiotic usage in ICU in the Indian scenario? Because we know the antibiotic burden in India is huge, the infection is huge. Antibiotics saved can easily be converted into the revenues saved for the hospital, but more importantly, you are discharging on patients at lesser cost with better mortality.
Dr. Diwan, I would request
That's the
you
last
to-
one.
Yeah.
And that is the tool which can be used to save more acute patients. This is our growth. We have not moved to 83, 85 beds. We have done thrombolysis through EICU. You can do septic shock management through EICU. You can do data analysis through EICU tools. Ultimately, that CN is about saving lives, and that is what the key is. Thank you.
Thank you, sir. I will now request Mr. Anil Bajpai, the co-founder and CTO of PMH Chelsea.
You would have seen disclaimer in movies that no animals were hurt during the shooting of the film. Similarly, those of us who have been in the corporate life would have heard death by PowerPoint. I assure you, I'm not going to make you die by